All right, welcome back. I'm Professor Adam Thompson. This is the second part of STE-Mimics. And in this part, we're going to talk about different causes of STE-Mimics. But first, I want to remind you, if you don't know what bundle branch blocks are, head over and watch the bundle branch block tutorial in the Resuscitationist YouTube channel. So left bundle branch blocks, it used to be thought that if somebody had a new onset of a left bundle branch block, that was indicative of an acute myocardial infarction. So if you had somebody that had a new left bundle branch block, you would call STEMI-alert based on that, and activate the cardiac cath lab based on that. But we know now that is old thinking. For about 10 years, we've known that there's no correlation between when a left bundle branch block occurs and an acute myocardial infarction. So here we have a left bundle branch block, and let's go through the EKG. We have our limb leads on correctly, all the electrodes are on correctly. Looking at this, you first see a sinus rhythm. Is what you have a P wave before every QRS complex. You may have a little bit of a delay there, a prolonged PR interval. And you'll also notice that your QRS complexes are negative in leads 2, 3, and AVF, and positive in lead 1, indicative of what we would call a pathological left axis deviation, which is indicative of a left anterior fascicular block. So you have that going on, but we know our QRS is wide, so whenever we see a supraventricular rhythm and the QRS complex is wide, we know we're going to move over here and look at V1. And if V1 is negative, a lot of people remember that turn signal method. So when you push down, because V1 is down, when you push down on your turn signal, you're turning to the left. So when you have a QRS complex that's down, it's indicative of a left bundle branch block. And then you would look, if you're really avid at 12-lead EKG interpretation, you would look over at leads 1 and V6 for a tall, upright, monomorphic R wave, and sure enough, that's what you have here. Okay, so this is a left bundle branch block pattern. No matter what the rhythm is, this is a left bundle pattern. And with that, you're going to get some ST elevation quite often with a left bundle, and especially in these precordial leads, especially the right precordial leads, where you have a negative terminal wave and a positive T wave. You have T wave discordance. And sure enough, if you look at where this isoelectric line is and you look at where this J point is, you have quite a bit of ST elevation there. And it is going to correlate and be proportionate to the depth of the preceding wave. So this QRS complex is actually really deep. You can't even see how deep it is because it's cut off, but it probably would keep on going down. So it's a really deep QRS complex. So the ST segment is going to be more pronounced. And again, you'll also get ST depression in the presence of a left bundle wherever the QRS complex is, upright, as it should be in V6. You'll get ST depression because that T wave is negative, the QRS complex is upright, the T wave discordance drags the J point in the direction of the T wave. Okay, remember that rule, and it's going to be pretty easy to identify these STE-Mimics. Here's another left bundle branch block. Again, you have a supraventricular rhythm, a sinus rhythm. You have a aberrancy, a wide QRS complex. You look at V1, and sure enough, you see a downright QRS complex indicative of a left bundle branch block. If you look at leads lead 1 and V6, V6 has that monomorphic upright QRS complex. Lead 1 has probably something we call lead 1 sign, which is indicative of a chronic cor pulmonale or somebody that has COPD. So you can't really trust anything you see in lead 1 because of the very low voltage. So just looking at this left bundle branch block again and these right precordial leads, you do have significant ST elevation. And I say significant because there's a lot of it, not significant because it's an MI. This is all related to the left bundle branch block, and there's not anything on the 12 lead that indicates that this patient's experiencing an acute myocardial infarction. I'm not saying you can't identify an MI in the presence of left bundle, because in fact you can. That was a myth that was commonly taught, but there is something called Scarbosa's criteria that we will discuss in another video. Here's another good example of a left bundle branch block pattern. Now this one isn't in fact a left bundle branch block. Can you tell me why? I'll wait. Yeah, of course you're not going to be able to tell me why, but you probably know. I just can't hear you. So if you're shouting, it's a non-specific intraventricular conduction delay, because that's so easy to say. Then you were right. This has a left bundle pattern in V1 and in V6, but if you look over here at lead 1, that's what it should look like with a right bundle branch block. So when your V1 and your lateral leads don't match the pattern that they should be for either bundle branch block, then it's considered a non-specific intraventricular conduction delay. However, this one, for the purpose of this lecture, does have the left bundle T-wave discordance that would cause ST elevation in the precordial leads. And it sure enough does, and it causes depression over in these left precordial leads. That was a bad arrow. That J point is depressed, right? So again, you're going to draw that line over to the TP segment and be able to identify that. Because you can never see too much of anything when you're trying to learn something, here's another left bundle branch block pattern. This is again a sinus rhythm. It's got aberrancy. You have a left bundle pattern in V1, V6, and lead 1. And of course you do see that very significant ST elevation in the right precordial leads, and maybe a little bit of depression over here in the left precordial leads. And you'll even see the depression in the limb leads. Again, it's going to be whichever leads are positive should have a little bit of depression. Whichever leads are negative should have a little bit of elevation. And if you know that rule, you might start understanding where Scarbosa's criteria goes, because if you start breaking those rules, then maybe there is something going on. Sure enough, I have another one for you. Nice sinus rhythm. Aberrancy, left bundle pattern in V1, V6, and lead 1. And we do have ST elevation in these right precordial leads. And maybe some depression in some other leads. I see maybe a little bit in AVL. Maybe a little bit in lead 1. Okay. So that is, it's just like a left ventricular strain pattern. In fact, you can call it a left ventricular strain pattern because it is the left ventricle that's being blocked. The conduction is moving much slower through there. It's just a different pathology. So a reminder, T-wave discordance is the key when it's coming to left bundle branch blocks and LVH or left ventricular strain patterns. The key to understanding those is understanding this rule of T-wave discordance. So we gave left bundle branch block a lot of attention. Let's talk about a right bundle branch block. So here we have a right bundle branch block pattern. You do have what people like to call the bunny ears in V1, but it's a small left bunny ear and a tall right bunny ear. It's a wider QRS. This one isn't as impressive as the left bundle branch blocks, and right bundle branch blocks typically aren't. But you have a terminal R wave in V1. It's upright or positive. Remember, you push up on your turn signal to turn to the right. And then you look at V6 and leads 1 for these slurred S waves, which are present. Okay, and it's important to note that sometimes people will not identify the right bundle branch block, and they will think that something like this right here is ST segment elevation. That's not ST segment elevation. What you're looking at is a funky R wave at the end of the QRS complex. And the way I know that is I can draw a line from the end of the QRS complex above it, and sure enough, that is part of the QRS complex, right? So this QRS complex is this one, it's just a different view, a different angle of view. So that's important to remember whenever you're trying to identify the different parts of your QRS complex or your EKG pattern. If you can't identify it in the lead you're looking at, so if I was trying to figure out where's the QRS complex in AVF, well, I would just look at AVL, and I could draw a straight line down from the end and from the beginning, And I would know that your QRS complex is that thing that you don't really have a good angle of view in AVF. So here's an exact example of that very thing. Here's a 12 lead EKG from a right bundle branch block that somebody thought was an acute myocardial infarction, and here's why. They didn't know where the J point was. So they thought in lead 3, they thought that was elevation. And in fact, that's just part of the QRS complex. And how do I know? Well, I can just look up here at lead 1, and now you can see the dotted line that I drew. But if you look here at lead 1, that's your J point. You know that because here's your T wave, right? And your T wave ends right here, going into that S wave. So if you drew a straight line down, like this dotted line does, then you'll see where the QRS complex ends. So that's not elevation, that's part of the QRS complex. Same thing in V1. You can see where the end of the QRS complex is. And again, the width of the QRS complex doesn't change in your typical rhythm, right? It could change if you were changing, you had ectopy, or aberrancy. But an ectopic beat might have a different width than the intrinsic beat. But in this rhythm, it's just the same the same pacemaker the entire time. There's no ectopic beats. So the QRS width is the same, even though it looks different. Like if you look at this QRS complex in V5, it looks very narrow. But it's not. Look at the one in V4. This is where it ends, right there. And that's where it begins. It's not a narrow QRS complex. It just looks that way. It looks like it's narrow in V6 as well, but sure enough, it's not. So that brings us to the end of this very short second lecture on STE-Mimics, where we talked about left bundle branch blocks and right bundle branch blocks, and how for very different reasons they can mimic an acute myocardial infarction. So we're moving right along with these STE-Mimics. If you want to go back to part 1, you can, or move on to part 3. Don't forget, if you're not subscribed, you're going to want to subscribe. I have a lot of different videos on different topics. I don't just do EKGs. We have drug math, we have capnography, we have all kinds of different videos in the channel.